Hello everyone, my name is Marcio Averbeck. I am a urologist based in Porto Alegre, the main city of southern region of Brazil, and it's my great honor to welcome here at the ICES Live Lounge during the ICES 2024 two researchers that are well known worldwide, Dr. Craig Comiter from Stanford, California, and Dr. Margot Damaser from Cleveland, Ohio. I'd like you to introduce yourself. And first of all, thank you for being with us at the ICS Live Lounge.
Thank you. So I'm Margot Damaser. I'm a professor of biomedical engineering at the Case Western Reserve University, and I have research labs in urological biomechanics at Cleveland Clinic and at our VA hospital in Cleveland, and it's a pleasure to be here at the ICS Live Lounge with both of you.
And thank you. I'm Craig Comiter from Stanford University Medical School, and I'm a professor of urology and of obstetrics and gynecology, focusing my clinical practice on urinary reconstruction and pelvic surgery, and focusing my research on male incontinence. And it's an honor to be here.
So, we had plenty interesting day two in the ICS 2024. It started with the state-of-the-art lecture presented by Professor Philip van Kernbroek from Belgium, bringing some insights about the Urge to Act manifesto, which was aimed to increase awareness about the effective treatment and assessment of urinary incontinence in Europe, which is something important due to the fact during the pandemic, functional urology has been neglected somehow, not only in Europe but in many countries. It was quite interesting to see Professor van Kernbroek discussing the economical burden of urinary incontinence in Europe. And I'm sure that you had the opportunity to attend very interesting sessions as well. I'll start with Margot. We've been discussing previously about some applied clinical science and also about the role of artificial intelligence in functional urology. I would like to know your insights, what you have attended during the ICS 2024. What are the points that perhaps will have an influence in the clinical practice and the way we treat our patients?
So I think the many papers here on the use of artificial intelligence is really promising and very interesting. It's being used in a variety of different ways to analyze genetic background and predict risk of different conditions, to better analyze and get more information from urodynamics. Most importantly, it's just beginning to be used to improve our phenotyping of conditions. You know, we all know there can be many causes of underactive bladder, overactive bladder, pelvic pain. And so to be able to sort this out from the data we already have in the medical file from the urodynamics, and I think artificial intelligence will be a huge asset in
I
that
guess you're
regard.
the right person to talk about artificial intelligence in urology, as we are one of the pioneers of wireless urodynamics. So most probably the concept of artificial intelligence and the application to overcome the lack of abdominal pressure tracing for wireless urodynamics is an example of how these newer insights and newer approaches are coming very rapidly to functional urology, and how it can be perhaps a changing point in the near future.
So I think it also has use. That's one example of how the artificial intelligence and machine learning can be used to fill in missing data. Like if we are missing abdominal pressures at home, we can fill it in and estimate it from the vesicle pressure data. But also to analyze big data sets. When we start measuring bladder activity at home, even if it's just a week, That's a lot of data to go through. But of course, as with any machine learning or artificial intelligence, it depends on the training sets you use to train the program, right? So we as a field need to be very careful not to bias our training sets, not to use limited training sets, to include everyone in the training sets.
The hype or the hope around
right.
artificial intelligence.
That's right.
I cannot forget asking about the newer technologies that we've been discussing, Craig, about male incontinence. Not only that, about urodynamics as well. You had a chance to attend interesting sessions on that, and you've mentioned that one of the big points about being the chance to attend such a meeting like the ICS 2024 is the chance to get to know about the technologies that are not necessarily approved or registered in different regions of the globe, so that you had a very interesting experience in the morning. Can you share it with us?
Yes. So, one of the joys of coming to the ICS is seeing old friends like the two of you, but learning about things that are new to me, although they may be routine to you, such as the Adams sling, not FDA approved. The Victo artificial sphincter, not FDA approved. The Uromems device, which is in clinical trial. These are things that we have nothing more than articles to read about, and not only do we get to hear the presentations, learn about the device, we get to meet the inventors, and this can start collaborative work. And it also makes my mind think about how can we tweak the device and maybe improve it. So it seems that about 90% of what I see here is new to me. So to me, that's the most exciting part.
Wow. And concerning surgical treatment of male incontinence, we had a conflict of interest here because we had a chance to work together in the 7th ICI. We've written together the chapter 10 on this surgical approach to male incontinence. Do you believe that the newer technologies are coming to benefit the patients? In which ways the presenters brought the application of these newer devices? What are your expectations concerning these newer technologies?
Sure. What you call a conflict of interest, I call a confluence of interest.
Oh, yeah.
But I think that we're actually migrating. We've reached a plateau of efficacy. And I noticed especially with the Victo device, with the Adams male sling, maybe we don't need to strive for completely dry or go from 80% improvement to 100% improvement. We seem to be focusing more on complications and getting rid of the need to revise these devices by actually lowering the pressure. And while these adjustable slings and adjustable artificial sphincters may initially have been thought of to improve continence over time, starting to think about decreasing pressure over time and maintaining efficacy rather than causing atrophy of the urethra. And then hearing about the new potential electronic artificial sphincter that not only can maintain efficacy because you won't have a balloon that could lose elasticity, you'll have a metal device that delivers a fixed volume, but you can also dial it down for the lowest pressure that's satisfactory and maintaining the health of the urethra. So it's interesting how the initial thoughts were to improve efficacy, and already it's migrating to how do we prolong the life of the device and omit the need for revision surgery.
Oh, this is highly interesting, and I was just figuring out whether reducing the pressure during nighttime in which the patient is not having a physical exertion or activities could be an interesting point behind the integration of electronic technology to the current artificial sphincters that we have in the market. What about urodynamics? We had a chance to attend a session on urodynamics, and sometimes we feel like based on the different databases and interpretation of data, urodynamic data, there are some new nomograms or new approaches to old problems, and we know that perhaps urodynamics is not a recommendation for all the patients, but what are the points you'd like to bring about urodynamics that you had a chance to listen to in the morning of day 2 ICS 2024 to the people that didn't have the chance to attend this meeting?
So I do think that urodynamics is used more frequently outside of the United States, especially in Europe and Latin America. So seeing what could be overuse of urodynamics, but at the same time seeing these large data presentations, that's the only way to accumulate data and know when is it indicated. And there were several presentations regarding the lack of predictability of outcome based on urodynamics. But the only way to know that is to do the urodynamics on so many patients and then learn that it may not be necessary. And now I know I don't have to do urodynamics, for example, on a woman with non-obstructive urinary retention. Now, other than the need to do urodynamics to see if she's obstructed or not, no other parameter, I learned, predicts successful voiding. So maybe we don't need to be doing as much urodynamics, except in the research forum.
This is, there are controversies are all around that, and it reminds me of the lecture that was delivered by Professor Paul Abrams in the first day of the meeting, in which he acknowledged that for male LUTs, and for LUTs in general, they are non-specific, so that he cited the EAU guidelines on male LUTs and indications for urodynamics, in which the first paragraph brings like whenever you need to know more about the physiopathology behind underlying physiopathology, you should consider urodynamics. Then he brought the issue, okay, but as LUTs are non-specific, perhaps you should consider urodynamics for all the patients. I know this is somehow provocative, but based on the upstream trial that showed that for male LUTs, for patients with BPE LUTs, the urodynamics, the patients referred for urodynamics initially in comparison to non-invasive assessments did not change the conduct and the follow-up of these patients overall. But I believe that for those ones that work more closely to urodynamics, the ones performing, as myself, we believe that urodynamics bring important information overall, and there will always be some controversy around that. So in terms of male incontinence, something that you work very closely, would you recommend this for a specific set of patients, for which patients that you believe will benefit the most of urodynamics in this context?
So I think one of the limitations of the urodynamics that we see here is this data is presented by experts. So maybe they are so good at evaluating the patients based on symptom and physical exam and simple uroflowmetry and have so much experience that that may be why the urodynamics is not predictable, because they've already selected out so carefully who should and should not benefit from further treatment. But I think for the non-specialist, urodynamics is indicated when you have a question whose answer changes what you do. For example, in post-prostatectomy incontinence, I still believe you need a good bladder in order to overcome the resistance of a fixed sling, whereas an artificial sphincter is opened and you can void by gravity or Valsalva through an open urethra. And there are presentations that show urodynamics does not predict success of the male sling, especially voiding. Well, that may be because you're so excellent, you already knew who had a good bladder and who had a weak bladder. So your urodynamics is not necessary for you, but it may be necessary for you.
This is a very good point.
And we need Margot and her wireless urodynamics.
Well, we need the artificial intelligence to try and
to phenotype the patients.
Reproduce what the experts know. If the experts can pull it from a chart, from the history, from the bladder diary, then maybe a computer, given broad enough training set, can as well.
Good.
And do you think if we gave an expert opinion, which we hope is true, on many uroflow curves, you could teach the computer how to recognize flow patterns and help with the diagnosis?
That's the hope. Yeah,
did I just figure out what artificial intelligence is?
Perhaps it's confidential. I don't know. Let's hope for the future that these newer technologies will bring benefits for not only for assessment but for the treatment of our patients. So Craig and Margot, thank you very much for being in the live lounge.
You.
And I'll invite all you not to miss the next editions of the ICS 2024 highlights. Thank you.